All right, we are ready to go. We're a little bit late, so hopefully the teams will be able to do the cases more quickly so we catch up. I'm David Cohen from Cardiovascular Research Foundation at St. Francis Hospital. My co-moderator needs no introduction, S.J. Park from Asan Medical Center. On the panel here we have Dr. Chiam, Dr. Kang, Dr. Kim, Dr. Ko, Dr. Lee, Dr. Lin, Dr. Park, and Dr. Zhu. I hope I pronounced everybody's name correctly. So we have two live cases, and then we have several lectures and discussion. So we should go first to Asan Medical Center to see Jung-Min Ahn come back for a reprise. Hi, Jung-Min. How are you?
Hi. Good afternoon, David.
Good to see you. What are you doing there? Looks like you're ready to go.
I'm very happy to see you on the screen. So welcome to SEOUL Valve again. So we're preparing the very interesting live case. This session is the TAVR for bicuspid aortic valve disease. We're preparing the type 0 aortic valve disease patient. So I'd like to introduce my teams, Professor Lee from St. Mary, Eunpyeong St. Mary Hospital, and my senior fellow, Dr. Seo. Dr. Seo will introduce our case.
Thank you for your introduction. I'm Kyung-Won Seo from Asan Medical Center. I'd like to introduce this case. A 74-year-old female was admitted for chest pain and palpitation from 1 month ago. She had a past medical history of diabetes, hypertension, hyperlipidemia, and her BMI was 24.2, and calculated STS score was 2.7%. Electrocardiogram shows sinus lesion, and chest X-ray shows no significant lesion. Echocardiography shows a normal LV ejection fraction, and AVA was 0.91. Parasternal long axis view shows limited motion of aortic valve and no significant AR. And parasternal short axis view shows anterior-posterior type of bicuspid aortic valve. And LV ejection fraction was 68%, and mean pressure gradient of aortic valve was 47, and transaortic valve peak velocity was 4.5. On CT findings, cross-section view of annulus and 2, 4, and 6 millimeter above the annulus. Annulus area was 387, and sinus valve was 771, and STJ was 801.
You can see the type 0 bicuspid aortic valve. Go ahead, please.
Yes. LVOT area was 372. And calcium volume of aortic valve was 142. Coronary height of LCA was 17.7, and RCA was 18.6 millimeter. Peripheral arteries was fine without significant heavy calcification or severe tortuosity. Minimum diameter of femoral artery was 6 to 7 millimeter. So the 23 millimeter Sapien 3 Ultra provides 5% area oversizing, and Evolut valve 26 millimeter provides 16 perimeter oversizing. So this is our TAVI planning using 23 millimeter Sapien 3 Ultra.
Okay, do you have any comment? Summarizing, this patient is a type 0 bicuspid aortic valve disease. The aortogram show that a little bit bigger ascending aorta, but the CT show that the ascending aorta maximum diameter is only 43 millimeters. So definitely that indicates for ascending aorta surgery. And different from the usual bicuspid aortic valve disease cases, the aortic valve calcification is very rare, very low. So only 100 is a very low aortic valve calcification, but bicuspid type 0 aortic valve disease. So do you have any comments?
So anybody on the panel, anybody not want to treat this with a TAVR? And would this patient get a TAVR in your center?
Yes, I think so. I think the anatomy looks suitable. So the coronary heights are high, and now with BFS3 UR, so I think this will be a good choice for her.
Anybody down here to my left? Anybody want to weigh in?
Dr. Ahn, I'm Dr. Lim from Taiwan. Because from outer grounds, I think that ascending aorta is a little bit dilated.
Yeah, I thought so too, but Jung-Min said it was 43 millimeters, Jung-Min, is that what you said?
So
Yeah,
what
right,
about
right.
concern
Based on the
about
CT.
the aortopathy of, because she's only 76.
70 in her mid-70s, so she's young. Yeah, I mean, I have to say I'm surprised that the aorta measured that small. If it was more dilated, Jung-Min, would you have her seen by surgery?
If the ascending aorta is more than 5 or 0.5 or something, then we consider the ascending aorta replacement, particularly patient age is young. But in this case, the ascending aorta size is only 43 millimeters, less than 5. And so even though relatively young, but this bicuspid is not that complex bicuspid aortic valve disease. So I'd like to do TAVR in this case.
All right, we'll let you do TAVR because we're here at a TAVR course, so we'll let you go. We'll let you do that. The original studies out of Cedars suggested that type 0 valves were not the best for TAVR. What are your thoughts about type 0?
Yeah, there is some, based on the literature regarding the peri-procedural complication, type 1 bicuspid that has a higher risk of peri-procedural complication than the type 0 bicuspid valve, particularly the very low calcification type 0, I think it could fall the TAVR.
You think this
But
maybe
the
is
one
ideal?
problem is the wire crossing through the valve is sometimes difficult in this case.
Well, maybe you already did it.
We'll
I hope
see.
so. We'll see. For it. All right, why don't you go ahead and tell us your plan? Oh, you didn't do it already, so
Yeah,
you get to
I did.
watch. Is that just a standard soft tip straight wire? You don't
Yeah,
use
this is soft
not a glide
wire.
wire or anything like that?
Yeah, soft wire first, and if I fail, I like to change to the stiff wire.
Is everybody on the panel's first catheter of choice an
Trust.
AL1 like this, or do you use something else? I see some nods. Everybody likes AL1? AL1 always.
This is the AL1.
Yeah. Yeah, it seems to be the winner these days, although I still sometimes like the JR4, but AL1 probably, you have more control, I think.
Can I have a question regarding the oversizing? According to the bicuspid type, these patients decide to oversize 10%. How about in case of the type 1 and so on?
I think we heard this morning that the Asan algorithm tends to be not to oversize in the type 1s, I think. Is that what we heard correctly, Jung-Min? I don't want to interrupt you much, but...
Particularly for type Sapien 3, so depend on the aortic valve calcification. Very severe calcification, just undersizing or pigtail, please. Just undersizing, nominal sizing or even undersizing. But the very low aortic valve calcification,
And you take care of your wire. Don't worry about
Yeah.
us.
so very low aortic valve calcification, the oversizing is similar to the tricuspid aortic valve type of cases, so 5 to 10%.
So in this case, that's why you're comfortable with a 10% oversize.
Yeah, because the calcification is very rare. But I'd like to replace the wire using the
Pigtail.
the
Yeah.
pigtail.
Good idea.
Jung-Min Ahn here. So can you just explain what area you're fixing to? Because this is type 0. You don't
Yeah.
necessarily want to use the whole annulus area to do this because the long dimension is too big. So maybe you can just go. I think you went through.
Yeah, be
quick.
careful.
What size are you? Once you settle with this first.
All right.
Yeah.
Well, all right, good.
Yeah, I think, where you're going to implant it, does seem, because it is, very eccentric.
Good.
And that's going to work
It
better.
is actually basically similar to the tricuspid aortic valve disease. Go away. So we selected the lowest portion of annulus and then measured the similar to the tricuspid aortic valve disease.
So I'm sorry, you said which portion of the annulus are you suggesting? Just the base of the annulus, or are you elsewhere?
Actually, it's very tricky, but multiple plane is important.
Multiple planes.
So the lowest annulus portion and smallest one, we pick up the device measurement.
Okay. Yeah, I think we
you-
Americans need to learn about bicuspids
Okay.
from Asia. Go ahead.
Predilation too, just do?
Yes.
Took that.
So initially, we didn't plan that pre-dilatation because our article classification is very low. But after insert the wire, the location is not that good. So that means that some portion seems to be very harder than what we thought before. So I'd like to do a pre-dilatation in this case.
So, and the size on this?
Yeah, test, please. This is 18 millimeter.
18.
18.
Okay, so kind of
Yeah.
small. Okay.
Facing on. Inflation. More contrast.
Small size.
Deflation.
Yeah, very small.
Facing off.
Go for it. Good.
That showed how small this balloon looks in that annulus, I think, which is very common, I think, with the bicuspids. The annulus is always, I mean, or the root is always large compared to the annulus.
Dr. Ahn, we just deploy the SAPIEN, right?
Yes, right.
All right. So explain that one. So actually, for particular this case, is calcium amount-wise relatively small, very small, and annulus size-wise, area
23.
less than 400 something is a relatively small one.
Yeah,
So
right.
maybe, what do you think? The self-expanding would be the more effective stent area, valve area, or something. What do you think?
So this patient, both the SAPIEN and EVOLU system, both are good because the aortic valve complex is very large. Even though the self-extended, even after the self-extended implantation, coronary access would be good. So I think both are good for this case.
Sure.
Does this patient have meaningful coronary disease or not really?
Actually, the patient has, we check the coronary angio based on the CT coronary angiogram pre-operative planning. Next.
Not too bad.
So, yes, not too bad. A very intermediate disease. So,
And she has coronary disease, but nothing severe.
Yeah.
Yep. Okay. Now, are you ever using the, I guess it doesn't really matter here, I can't really talk about it. I was going to say you're using the cusp overlap view to deploy the balloon expandable valves, but there is no cusp overlap here. You've got two
balloon
cusps.
expandable valve? No, I didn't do the
No.
cusp overlap view for the balloon expandable valve implantation.
Anybody using it? Anybody?
No.
Anybody? Nope. I mean, you can, obviously. It works just fine, and you can use it in the same way that you use it on with the self-expanding valve. You just can really control the depth perfectly. But obviously, we're all very experienced with doing it in the three-cusp view. It makes it very familiar looking.
I have one question. So I think that this patient have a relatively larger sinus of valsalva. So I think there are little chance to damage the aortic root. So why don't you place the pigtail on the annulus tip in this patient? It's your routine.
Yeah, usually we place like this, but during the implantation, I put a little bit more to the ascending aorta.
Angle, right?
So who on the panel routinely pulls the pigtail back before the valve deploys, and who leaves it in? So put your hand up if you routinely pull the pigtail back before you deploy the valve. So we have pull.
I leave it there.
Leave. Down here. Leave.
Test, please.
More votes for leave. Okay, I'm on the leave side too. Has anybody had a horrible problem from leaving the valve down there? They pulled the valve out? when- I haven't yet, so knock on wood.
Jian'an 6, nominal.
Test,
Jian'an
please.
3.
Yeah, it's going to be a funny look because you don't have a 3 leaflet, 3 cusp.
Yeah, that is a big problem. So to make sure the best implantation angle, we need a multiple projection. Test, please.
What are you? Are you in an almost AP here? What are you in?
So this is the selected view for best implantation.
What's the angle?
Ready?
All right.
Patient on. Contrast. Okay.
Okay.
Inflation. Best. Okay. 1, 2, 3, 4, 5. Deflation.
Great.
Patient.
Now everybody laughs.
Patient
Yeah.
off.
I think we count slower though in the United States. We think we do the same exact amount of time, just we count slower.
Remove.
That looked very nice.
In this case, if you choose self-spinning valve, will be more challenging because it's a little bit horizontal.
Yeah.
Outer,
Yeah. I mean, that also is obviously is a reason to choose
Low calcium.
the. No, I mean, almost no calcium. Yeah. But the horizontal route can always. I mean, just the parallax issues and things like that are so hard sometimes with the self-expanding valves.
So we leave with
Let's see how you did.
a little bit. Okay.
And that was Jung-Min. Was that +1? Were you +1 on your volume there, or is it nominal?
+1.
+1. Okay.
Ready? Okay. Could you show the echo, please?
It's got wire related.
Yeah, it's something. I mean, it looked like it wasn't there, and then it showed up. You may want to pull the wire. Yeah, that might be it.
I think the contrast leakage is due to the wire, not
Yeah. You want to take the wire out and do it again?
Yeah.
Mainly central.
So for the bicuspid aortic valve disease, our sizing is totally dependent on the aortic valve calcification. In this case, the very low aortic valve calcification similar to the tricuspid aortic valve disease treatment. So what is your usual oversizing in tricuspid aortic valve disease? When you use the sapient 3, Cohen, David?
Maybe 10 to 15% is fairly typical.
Okay, would you show us the table for area oversizing 23? Dr. Ahns, I think it's maybe
Previous.
we have some discussion point over there.
23 is a 5% oversizing.
23?
So we added 1 cc more.
1 cent more.
So around the 10% oversizing.
Around the 10.
Yeah.
Yeah.
So I think,
10.
I mean, that seems very reasonable given, very, very little calcium.
Low calcium.
And so I think that was a good choice. Should we go back to the echo? I think we were looking at the echo. I didn't see much.
So could you show us the echo? So if a patient have very high calcification, I will reduce the volume. So less than 1 cc less or 2 cc less. So I would like to make a 0% or sometimes undersizing valve in case of very severely calcified valve.
Mainly central.
Diastolic pressure is around 50. So I think
No
You
PBL.
see it's on the wire. I think you need to just take the wire out.
Yeah.
And you'll-
Wire related. Good.
Nothing paravalvular. I don't see.
Okay, I'd like to remove the device. Wire please. And then change it to the pigtail.
Sounds good.
Professor Ahn, This
Yes.
is Euihong from Japan. Can I ask one question?
Yes,
What is the
please.
cutoff value of the calcium amount to do the downsizing for your center?
So in my mind, and in our center, reduce the volume when the calcium volume is more than 1,000. More than 1,000, we consider it a very calcified aortic valve disease.
I think that volume is measured by the 850 threshold, right?
Yeah, usually 850. The remainder software provided, automatically provided that
Thank you.
the calcium volume.
We don't
So
see,
we'd like to measure the pressure.
Yeah, we don't see LV pressure yet. There we go. There we go.
Yes, LV pressure and aortic pressure looks very fine. So I like to check the aortogram and I like to remove the wire. Ready?
You're going to take the pigtail out, or you're going to leave it in?
Yes. Check the for live demonstration. I will just check the aortogram first. Ready?
Yeah.
Okay,
Yeah,
very
it's much
minimal.
better. Yeah. Yep.
Yeah, very minimal. So
Yeah, I think that satisfies me.
clinically very insignificant. So I like to move the pigtail and then taking a final shot, and I like to finish the procedure.
SJ says
So,
sapien is simple, which is one of its great attributes. Oh, that's
Perfect.
fantastic.
Perfect results. All
Yeah.
right.
Actually, procedure is very simple, but the pre-procedure planning is not that simple. So particularly the bicuspid aortic valve disease. So we have to spend more time before procedure, not during.
Yeah. Well, it's always better to spend the time before,
right.
because you prevent spending a lot of time during, I think, which is the goal. Well, that to me looks like a very beautiful result, Jung-Min. You know, I think
Good
we
cases,
really
right?
appreciate your teaching us so much about bicuspid disease, because certainly we still have a lot to learn about it, but I think you guys are masters of it. You have really made it into a science, and that's a wonderful thing. So
Great.
thank you so much
Great
for a
case,
wonderful
right.
demonstration.
Thank you.
We're going to move to China, from China. Second affiliated hospital, Zhejiang University. Dr. Jian Wang, can you hear me?
Hello, Dr. Wang.
Hi, hello.
Yes, go ahead, SJ.
Right, go ahead.
Hi, thank you. Thank you all for joining us. Can you hear me?
Yes, we hear you fine. This is David Cohen, and my co-moderator is SJ Park, and we have a great panel here, so we're looking forward to your procedure.
Thank you for joining us, Dr. Wang. It's great.
Okay.
All right, we'll just start
Okay. Thank you for all of panelists and all of audience. Welcome you to our live demo. So first, let me introduce my colleagues, Dr. Liu, standing next to me, and also Dr. Wang, and all of other colleagues. So now I invite Dr. Liu to introduce the case. Welcome you, Dr. Liu.
Okay, Professor Wang. Okay, good afternoon, everyone. Yeah, today the patient is a 71 years old gentleman. The patient has a recurrent exertional dyspnea for over 3 years and aggravated for 20 years, and the echo showed severe stenosis, and the patient has a history of uremia. Next one, please. And the New York heart function of this patient is grade 4, and the patient is very small gentleman, and the BMI is about 16.7. And we evaluate the surgical risk. The TS score is over 8%. That's because of the end-stage renal disease and the patient condition. So the open heart surgery was denied by both of the cardiac surgeon and the family members. Next one, please. And this is the echo. You can see the left ejection fraction is quite low, about 38%, and the coronary looks good, no intervention needed. Next one. Yeah, we can see right here the patient is a typical type 0 bicuspid, and also we can see the calcification in the left coronary side. Yeah, and the area of the valve size is about 565 millimeter square, and the parameter is 87.5. So next one, please. The coronary height is good. Next one. And another problem of this patient is the dilated aortic ascending aorta is about 50.6 millimeter, and the calcification is asymmetric and not so severe. And the projection for this patient is RA06 and a Cohen 29. Next one, please. And we can see right here that the access of the femoral artery is good. So, however, the aortic arch is very narrow. You can see right here. Next one, please. Yeah, so for this very high surgical risk patient, yeah, there are so many changes, the challenges. Type 0 bicuspid, autopsy, and a large annulus with a symmetric calcification, and a very narrow aortic arch with horizontal aorta. Yeah, so next one, please. So what's the strategy and the projection for this patient? Yeah, in our center, Professor Wang developed the Hangzhou solution and also included the projection for this patient. So we usually, the catheter inserted by the tricuspid valve is divided into to create a virtual NCC and the RCC for the overlap, just like the tricuspid. And for this patient, yeah, so we just use the Chol and the RAO and the Chol, the same, the catheter level view with the coplanar view in the same projection in this patient. Next one, please. Yeah, for every patient of the bicuspid in our center, we will use the Hangzhou solution to select the valve size. Yeah, we will use based on the CT scan. So we will choose the proper size of the balloon. If there's a severe waste and with no regurgitation, then we will downsize the choice of the valve. Next one, please. And today, we will use, because this very special patient, that then we can discuss which valve type, which valve size, which balloon we should choose for this patient, we can discuss. Next one, please. So, today we will use the balloon expandable. It's the domestic, the Chinese-made domestic valve, and the design is quite similar with the Saving 3. Next one, please. Yeah, for the teaching points, yeah, for this kind of patient, so which strategy, TAVR or SEOUL? Yeah, and also the valve type, so the self-expanding or the balloon expandable valve, and also the valve size. So in our center, we will use the Hangzhou solution, and also for this very special patient, the skill, the technique in very specific complex. So for this patient, we just spend a lot of time for the valve crossing with the wire. Yeah, it's not easy for the manipulation. Okay, that's all for the case presentation. Professor Wang.
Hi, I would like to have your comments on our next step. So just around several discussion points. So what is, if the patient is yours, what is your next step? Are you going to do the balloon inflation or you're not going to do? Or if you agree with the balloon inflation before the device implantation, which size of balloon do you prefer for the patient?
So for this patient, we will use the balloon expander for 26.
Okay. So first first I would like to the panelists, for your comments and suggestions. Regularly, do you for this kind of patient, regularly do you do the balloon inflation first, or you didn't do balloon inflation?
Anybody want to weigh in on that that comment? About pre-dilating this valve? If not, I will. I mean, I think we have all been taught that bicuspid valves are tricky, and we should generally try to pre-dilate them. And as we saw in the slides, we can not only make it easier to develop and deploy the valve, but we can also learn something about the sizing when we do that. So hopefully that's, since you're the one who developed the technique, hopefully that's what you'll be doing. Yeah, so I think the idea of inflating with a balloon is a nice one, but we're not. Well, you got somebody strong put those together, huh?
I think personally, I see we still have a lot of way to sizing. Use like circle method or like the waste method to sizing, because using the Hangzhou solution sizing method, I'm a little bit worried about that, because when you do the balloon dilatation, your valve is not yet prepared. So once you have a acute aortic regurgitation,
so you have to be ready.
Yeah. But because the Hangzhou solution is that it depends on your balloon inflation, contrast injection to choose the size. So properly, that I think
so you have to have the solution already before you even blow up the balloon, is what you're saying. That I mean, I think it's. I mean, well, we'll see how you do it, but I think. I mean, I'm becoming increasingly convinced that we should pre-dilate, and then and take a look with the contrast injection to see how the balloon seals. And so I guess I would use a nominal size balloon here. But tell us what you're
from
going to do.
your comments, you will do pre-dilatation. So you will do pre-dilatation, but you will select reasonable size, not the size too big, because you are concerned about the regurgitation after dilatation.
That's what I'm hearing. That's my feeling. But we don't treat as many bicuspids as you do, so I really do want to see how you do it, rather than how I do it.
23.
So we select the balloon size is 23.
23.
So we are
small.
So the pre-dilatation 23. So the pre-dilatation has two purposes. First is to pre-treat the valve. It's easy for implantation of the device. The second purpose is to size how big we can open the orifice. It's good will be a good reference for us to select the device size. So the two purposes. So if we use a too small balloon, we cannot provide we cannot get the information how big size of device we can select. So we just regularly we use one scale less down, one scale right down size compared to the annular size, right?
Yeah.
Okay.
So that's a balloon size. So now we select the 23 balloon. Which type of balloon is it? So now we go through the valve.
23.
So we put the calcification site in the middle of the balloon.
Mm-hmm.
Then we are going to do a balloon inflation. So 准备起搏吧。
好，
等一下我做 DSA 是吧？
对，
这它撑起来再 DSA。
等会他会打的。
啊。
对你准备好了吗？好，
好 ，start pacing，
起搏，
起搏。
180，好，不好意思 DSA。我再拉回来，拉回来，预备打。来完的时候再升起来，好，哎呀
，stop，
有没有停？
Sometimes it's very stable. It's very difficult to stabilize the balloon, during inflation. So it means the pacing is not fast enough.
Yeah, maybe 200.
So now the blood pressure is recovering. So don't worry too much.
Okay.
So we have to pace the pace rate. We have to increase the pace rate. Maybe
200准备，
你抽空一点。
抽空了，好，好，差不多，好，可以稳定了，好，起搏
，Stop pacing, please. 200。
好，王老师可以，PSA，可以挺好，王老师，上不来一点，好7，PSA，起搏停，好 ，OK。
It's a little hard to stabilize the balloon, but we still achieved our purpose. So we can see that after we inflate the balloon, the whole balloon, we can see that no regurgitation, but we didn't see the waist of the balloon.
Can you replay that shot so we can all look at it with you?
你再回放一下，Go back，
来，
回放，回放。像他们还是不够，他还是在摆动。
So the waist is gone.
Can you see that?
Yeah.
The waist is gone, no regurgitation. So usually for this kind of situation, we didn't do the downside plan. We just use the regular size of device.
Yeah, 26.
26.
Yes.
So why do you say that?
你是用的不能
Yeah.
It's a regular way for the self-expanding device.
Yeah. What would
for this case we
Go ahead.
Keep on going, please.
My question is what could you have seen on this balloon inflation that would have made you want to downsize a balloon expandable valve? What might have changed your mind?
So during the inflation of the balloon, if we see the clear waist sign on the balloon without a contrast back to the left ventricle.
So if it was a waist and it was occlusive,
two sides.
Okay, then you would downsize. Okay.
Waist sign plus without no regurgitation, contrast regurgitation. So we will downsize one scale.
Got it. Okay. So you're going to go back. You're going to use the 26 though, right?
Yes, we are going to use the regular size. But this case, we usually use the self-expanding device for bicuspid. But this case, we had a discussion before the procedure. We think maybe it's better to use the balloon expandable device. The case is very fragile, low weight, BMI is very low, and also ejection fraction is not good. It's only 38%. Actually, our surgeon declined the surgery on the patient.
So why did you choose the balloon expandable? What made up your mind?
So Dr. Liu, could you?
Yeah. So there's several points. The first one, because the aortic arch is very narrow. Yeah, it's very good for the balloon expandable. Yeah, we can just cross the arch very smoothly. And also, because of the aortic of the ascending aorta over 50 millimeter, so we want to just one inflation and finish the procedure. And also because of the low LVEF. So if we use the long and the self-expanding, so maybe there's some problem with the crossing the arch. And if we just use the retrieve, yeah, the reposition bubble, so maybe it's not good for this patient.
So another reason maybe for this patient, the patient doesn't have the calcification of the annulus. For some patient with the calcification of annulus, we need to concern about using the balloon expandable, because balloon expandable device has the strongest radial force. So we are worried about causing the annular perforation. But the patient does not have the annular calcification, so we don't worry about too much the radial force of the balloon expandable device.
Sounds good. So are you ready to
also
go?
Also because yes, we are ready to go.
Are there any meaningful differences between these? Go ahead. Sorry, I'm sorry to interrupt. Go ahead.
So balloon expandable device has a relative the small profile, so it's easy.
Does this valve come with an expandable sheath?
Domestic made device. There's
这是 homemade production.
there's some different with that of the saving stream, including the
But
sheet
getting progress. Getting
and also
progress.
the valve itself. You can see.
你把心脏抹到当中来。
好，
Good.
来，
Homegrown sheath. Okay.
Professor Wang and Liu,
这是
is this domestic balloon spinal valve from China is different from anything different from the sapien valve?
Okay, I invite Dr. Liu to answer the question.
yeah. So the sheath is different, and then the valve is also already loaded.
So it's mounted on the balloon.
Yeah. You can see right
再移
here.
一下，再移一下，不太容易出去，就这个
跳在这里吗？跳在这里，跳在这里。
啊。
Does it come in? Is it more like the MyVal? Does it come in more sizes, or is it more like the Sapien in the sizing?
有什么不一样？回答一
Yeah,
下。
the size is the same. 20, 23, 26.
Same as the Sapien.
等
Okay.
一下吧。Yeah. So, however, it's already loaded.
Yeah.
Oh, it's a different from the sapien. Is the sapien is when we
我等一下啊，
already loaded
这个
before we before we put the device in. Actually, it's already loaded.
Yeah. 我是你轻轻往里边。
You can see that?
我是慢点，
Yeah, it makes it simpler,
是拉一点，
even
我是拉一
simpler.
点。我是等一下，
那你要往这后面拉一点。
这个他拉的，我是他在拉，你慢慢紧，慢一点。我是
这个
慢一点，
细是小。
慢一点，我是慢一点。好，他达到 Copeland view 来，我稍微慢一点。
Now we are going to the projection of a coplanar view.
Yes.
Mhm.
OK.
不要污染掉，你们这后面。
我是
It was 26.
26.
26. 我是好，等一下慢一点，我是。好 ，OK，good。OK。来，我是你这个出来好了，把这个出来。
你拔。
我出来 ，OK， 好。然后诸位重新弄一下。好，我知道。
Is this deflectable, or is it just
Well,
just like a balloon? The catheter doesn't look like it's deflectible.
啊，就是往下往上收。
对，
我们要 push
下
forward，
去多一点，
下去一点。
好 ，OK。
那有实力码
力量稍微松掉一点点，力量稍微松掉一点，是吗？力量稍微松掉一点点，我等会还会往里边走。我觉得可以先180，我们先试一下，拿个照镜看一下。
啊，
很高啊，是吧？可能再下去一点点。好 ，OK， 好，
我们最后照你看到吗？
对，实联动，我们180起搏一下，我们再起搏以后我们再试一下，等会再停起搏。谁在管起搏？对，我们起搏先试一下，等会再停掉啊。什么都不做，王老师啊。听王院士指挥啊。
哦，你起搏吧。Stop pacing, please.
好，好，挺好，停起搏。
停起搏。Stop pacing.
可以。
Blood pressure comes back.
Yes.
Now we just make judgment about the height of the device.
可以往回拉一点，
要拉了，
可以，
好，它马上说了，
可以
，180够不够？
可以，那么就200也可以，好，那就您指挥啊。
怎么样 ？OK，
好，
这谁来把这个啊？
王厉害把啊。
OK， stop pacing, please.
200
beats per minute. Stop pacing. 起搏。
好 ，DSA， 我说起来了啊，
去。
好，拔掉，我稍微顶掉一点，顶一点。
1、2、3、4、5。
好，起搏转下来，
转下来，
再到，好，再到转下来80。我稍微等一下，稍微等一下，等一下。
请你转。
啊，等一下。再转下来。
Really rotated.
好 ，OK。
QRS complex become wider.
打平。
懂了 ，come back.
打平。
Good.
把瓣膜打平。来，来。
There you go.
下来一点，厉害，下来一点。
Can you show us the deployment again? It seemed like it rotated quite a bit as it was.
Okay. Could you go back?
Just interesting to me.
Playing back.
Like-
再上来就不行。
Maybe not. Maybe not.
对对，挺好的。
前面
Maybe I misremembered. Look, it ended up more horizontal than I thought it would, but
You can see
a little bit, but not much.
a
Not
little
much.
bit shortening.
Yeah.
The distal edge has a large shortening, right? Has a big shortening.
Yeah.
Compared with the sapien 3. Compared with the sapien 3.
Cross wave.
I think it
So
shortened.
now you can see that hemodynamics is a quite stable. Blood pressure is 190 over 54. Heart rate is very good with a narrow curve complex.
Yep. Looks very good. So do you think
So
this?
we don't know whether the patient has a. So we can check an echo now. We can check a
好来，长征。
chest.
好，OK。哎，我们再把那个。
So usually we didn't do the TE for TAVR patients. So this patient also we just do the
我们顺便把那个血流动力学。
transthoracic echo. 你把这个探头。
好，到时候我们把朱伟先放进去。
So now we are going to put the pigtail in
Yes.
the left ventricle. Then we do the.
Check the gradient.
So now we check the pressure gradient first. Then we do the echo.
Sounds good.
So now the pigtail in already. Okay.
好，
在这行车中。可以啊。
好。
Clear.
Don't see any AR there.
Now we are checking the blood
Gradient.
pressure grading.
呀，这里也没有什么反流。
So can you see the echo?
We see the echo.
Can you see
Yes.
the echo? It's a five chamber view.
Yep.
From the five chamber view, we didn't see any regurgitation. So now we are checking the blood pressure grading.
Velocity is about less than 2. Less than 2.
The velocity, the peak velocity is less than 2, right?
Yes, less than 2.
Less than 2.
7.
The pressure grading.
Yeah,
Yeah,
mean is 7.
Okay.
From echo 大概 about 7.
Yep.
Now we check 0.
Yes, sure. Yes. Okay, you can see. 再调一下。来，我们把血流动力学放到桌面，换一个。
So it looks very
Yeah.
very
Gradient,
equal there.
Yeah, very good.
No gradient on hemos.
Yes. Yes.
No error.
Nothing by echo.
我想可以了。好。So we will do the final shot.
We do
来，
a
我们打
aortogram now.
Pigtail 出来吧 with the jaw the pigtail. So you can see that almost the pressure grading almost disappeared.
Yep. Looks good.
15连
Looks great.
And now we pull back the pigtail, then we do a final shot
That's
in the
right.
aorta. Okay. 来吧 So we like to get the Y in, then take out. Okay.
Yes.
Now we are going to final angiogram to see what is going on.
Yeah, please.
准备好了吗？15
对了
15吗
15联动。
？Okay.
Perfect
It
result.
looks
Okay, sir.
can't be better.
Even shorter than sapien 3. I think the domestic production device is shorter than sapien 3. Very short.
It looks very short. I mean, it looks like the old
So
XT. You know that. Yeah.
you're right. You're right. Because of very short, so we don't concern about too much about the blockage of the orifice of coronary artery.
Yeah.
So,
Yeah, that's remarkable.
any more
short.
comments? Welcome your comments and welcome your suggestions?
Any of our panelists have comments or?
So I have a question. So the system is very interesting. So my question is, if necessary, you can take out the valve before implantation? You mean the suppensary we cannot take out the valve?
So can you remove it through the sheath? I doubt it, but can you take this valve out if you
the sheath? Yeah.
Before you deploy it?
Put the valve out. Yes. Yes, we can take it out.
You can get it. You can get it back into the sheath.
Yeah.
How big is the sheath?
Yeah.
What French sheath are you using now? 8.
So this is the
18 French.
18 non-expandable.
16 French.
16.
16.
But is it an expandable sheath or is it a fixed sheath? It's a
expandable.
It's
expandable.
16 French expandable. Okay.
We don't need the pullbacks. It's just
yes.
Yeah, for that. Well, I think that's a beautiful demonstration, and really thank you so much for educating us about the Hangzhou solution, which I think is a very novel approach, and showing us a new valve, which looks a little like an old valve that we know, but really worked very, very well in this patient. So I think it was very, very educational. The SJ, you want to?
Okay, thank you.
Off?
All right.
Yeah, no, I think
it's great. Very interesting things. Dr. Wang, you just decide the tip size depending on a pre-balloon size, right? 23.
The smaller balloon.
And then smaller balloon, and then choose a 26. Okay, great.
I think this was we saw two different,
right.
two different bicuspid cases. Both used balloon expandable valves. Slightly different sizing algorithms for both, and both got perfect results. So hard to argue with success. Thank you so much, Dr. Wang, for joining us today.
Thank you all.
Thank you.
Okay. So now we are going to learn not from cases but from lectures. So we have coming back to the podium Professor Hayashida from Japan, who's going to talk to us about anatomy-based planning tips and tricks for bicuspids. I think we will know everything about bicuspids between you and Jung-Min after this.
Thank you very much, David. So, ladies and gentlemen, today I'd like to talk about the TAVI in bicuspid aortic valve anatomy-based planning tips and tricks. So actually, I always respect this the method to identify the smallest part of the aortic valve complex. If the patient have the flare types, we usually respect the size of the aortic annulus. If the patient have the taper type, I always respect the level of raphe, because this part will be the smallest part of the aortic valve complex. And for example, this patient have the aortic annulus area of 372. However, if you look at the little bit higher level, and we always measure like this, and the intercommercial length was the 20-something, so that means still we need to a little bit undersize the size of the valve to avoid any potential complications. And for example, this is the 77 years male who developed the severe aortic stenosis with peak flow velocity of 4.4. And if you look at the CT scan, the area of aortic annulus of 500. On the other hand, the intercommercial length was 24.4. That means the aortic annulus require a 26 millimeter sapien 3. On the other hand, we need to underfill 26 millimeter sapien 3 because the intercommercial length was 24.4. And this patient have the type 1 RN rapid. That means there is some risk of the left main occlusion. However, the height of the left coronary artery is good, and the intercommercial length was 24.4. Therefore, we decided to proceed with the 26 millimeter sapien 3 UR with 2 cc underfilling. And what is most important is to perform very good pre-dilatation with the 23 millimeter Edwards balloon, to see that how it works and to have some impression from the balloon sizing. And this is a balloon sizing. As you can see, there is a huge calcium chunk on the right and the non-coronary cusp. And we try to deploy the valve a little bit high, but not too high. And to cross the aortic valves, we usually inflate the tip of the balloon a little bit to avoid any friction. And this is the deployment of the valve. And the valve itself was pushed towards the direction of left coronary because the rough never opens up. And finally, it's almost the zero position because the smallest part of the aortic valve is complex, is a little bit higher than the annulus, so the position is okay. And this is a post-procedure CT scan which demonstrates the under-expansion of SEPIN. However, we didn't see any PVL at all. And this case is 87 years old male who developed severe aortic stenosis and peak flow velocity was 4.7. And you can see the LVOT classification at the 5 o'clock. And the perimeter was 80 and aortic annulus 495. And the intercommercial length 129, quite spacious. So therefore, this is the smallest part of this patient was aortic annulus. And we also need to take care of the LVOT classification. So therefore, we proceed with the Evolut FX 29 millimeter after pre-dilatation with ZMID 22 millimeter. And we always perform very good pre-dilatation. And we try to deploy the Evolut not too high, not too low. And this is the final angiogram. However, we didn't inject any dye because the patient had the CKD. And this is the post-procedure CT scan. If we put the self-expanding device, the metal doesn't expand that well. However, the biprosthesis is located a little bit higher position, and we didn't see that much PVL. Despite of the LVOT classification, it should be okay. And this third case, 83 years old female, she developed very severe aortic stenosis with peak flow velocity for 5.4. And the aortic annulus was 409, and the intercommercial length was 24, and the sinus of Valsalva was quite spacious. And this is type 0 bicuspid valve. And we decided to proceed with SEPIN 3 UR 23 millimeter after pre-dilatation with 20 millimeter balloon. And as you can see, we perform very good pre-dilatation. We also position the valve with the inflation of the tip of the balloon to negotiate very stenotic bicuspid valve. And sometimes the case with bicuspid valve have a little bit dilated ascending aorta. And to minimize the risk of the aortic dissection, we usually inflate the tip a little bit. And we deploy the valve with 1 cc endo filling. We can also see how the calcium behave during inflation of the valve. You can see stop at this point. And we always identify the minimal requirement for the contrast and maximum contrast inflation. And the post-procedure CT is like this. This happened always demonstrate a very circular shape of the stent and no PVL at all, even though the patient have the type 0 bicuspid valve. And one question is balloon dilatation mandatory for bicuspid TAVI? And this case was also type 0 bicuspid valve. And we performed the pre-dilatation with 20 millimeter balloon. Immediately after the BAB, so the patient developed acute AR, as you can see. And finally, we deployed the valve immediately because we always prepare the SEPIN before pre-dilatation in order to put the valve as soon as possible in case of the acute AR. And this is the final result, very good result. And the patient also had some residual mild to moderate AR because of this kind of calcification, so we don't need to take risk. We always take into account the pre-procedure degree of AR if the patient can tolerate the residual AR or not. And we had the OCEAN family, including 30 centers, and we already enrolled more than 25,000 TAVIs at the end of last year. And we published more than 160 papers so far, including 128 papers on TAVI. And our good friend and colleague, Dr. Futoshi Yamanaka, published the data that we compared the bicuspid and tricuspid, and bicuspid anatomy was associated with the less moderate to severe PPM compared to tricuspid valve. And survival was quite similar between two groups. The reason why the bicuspid cohort had the lower incidence of moderate PPM was presumably due to the less impact of the pressure recovery, because the ST junction is usually bigger in bicuspid compared to tricuspid. And in conclusion, ladies and gentlemen, individualized sizing strategy is essential for optimal valve sizing in bicuspid anatomy, and tailored use of balloon expandable or self-expanding device, along with the appropriate pre-dilatation strategy, can reduce procedure risk. And despite the anatomical challenges, bicuspid TAVI has demonstrated favorable hemodynamic and clinical outcome when performed using a personalized approach. So thank you so much for your attention.
Thank you very much, Kentaro. It's a very nice presentation, and I think we'll have some questions after. And now back from the cath lab, I finally let him out. Jung-Min, welcome. And you're going to tell us about the Asan approach to bicuspids?
So there are many clinical and anatomical challenges in bicuspid TAVR. So bicuspid TAVR usually younger and less comorbidity, more severe aortic valve calcification, large aortic valve complex, more severe aortic valve calcification, and also bicuspid aortic valve. Based on our REGIS data, clearly show that the bicuspid aortic valve done in younger, most male. The usually tricuspid aortic valve disease is female predominant, but the bicuspid younger and male dominant. And so definitely we need a more optimized result. Lifetime management is necessary, and valve longevity we have to consider for bicuspid aortic valve TAVR. In addition, younger patient, less than 60, the 65% of patients have a bicuspid aortic valve in a surgical series. 61 to 70, 60%, 71, 80, 42%. So if we do the TAVR in younger population, we will meet the more frequently the bicuspid aortic valve disease patient. So in addition, bicuspid aortic valve has more severe aortic valve stenosis. The transverse aortic valve velocity is higher than tricuspid aortic valve population. In addition, CT shows that the aortic valve complex is larger, coronary height is higher, and in addition, asymmetric. The CT shows that the bicuspid aortic valve has a larger and asymmetric aortic valve complex. So like this, very asymmetric and larger aortic valve complex. In addition, most important characteristic of bicuspid aortic valve is calcification. The calcification in bicuspid aortic valve is 2 times higher than tricuspid aortic valve. In our REGIS data show that the tricuspid aortic valve calcification volume is only 300, but the bicuspid aortic valve mean aortic valve calcification volume is 600. So basically, bicuspid aortic valve is more severe calcified aortic valve disease. In addition, some characteristic is associated with high risk of periprocedural complication. Very severe calcification, LAPEC calcification, and alveolar calcification. Combined these calcification characteristics, we should be cautious when you do the TAVR for bicuspid aortic valve disease. I think this is a very important chart. In our centers, according to the aortic valve calcification, basically we apply the similar sizing selection criteria to the bicuspid aortic valve or tricuspid aortic valve, but totally depends on the aortic valve calcification. If calcification is very significant, more than 1,000, we reduce more. So nominal, starting with the nominal or sometimes undersizing. This is bicuspid, blue is tricuspid. But the aortic valve calcification is very low, rare. We apply the similar sizing algorithm even in the bicuspid aortic valve. similar to the tricuspid aortic valve. My previous live cases, aortic valve calcium volume is only 100, so I applied 10% oversizing, even in bicuspid type 0 aortic valve, bicuspid aortic valve disease. So calcification quantification is very important to decide the TAVR device sizing in bicuspid aortic valve TAVR. So usually, because of severe calcification, usually we do the less oversizing in bicuspid TAVR. In addition, because of very severely calcified valve, the larger the aortic valve complex, aortic valve TAVR for bicuspid aortic valve, we use the larger transcatheter heart valve and more frequent pre and post dilatation. It causes some complication during the procedure. But procedural complication, instance of procedural complication seems to be acceptable between the tricuspid aortic disease and bicuspid aortic disease. TAVR procedural TAVR complication is not that clinically significant, not significant different. In addition, during the 2-year follow-up, similar to the Ocean TAVR registry data, during the 2-year follow-up, between the tricuspid TAVR, bicuspid TAVR, the effective orifice area at 2 years, bicuspid TAVR numerically bigger than tricuspid TAVR. That is due to, even though less oversizing, basically bicuspid aortic valve is larger than tricuspid aortic valve. So when you compare the tricuspid aortic valve TAVR, bicuspid aortic TAVR, less BPM and larger effective orifice area. So clinical outcome is acceptable. But the problem is still remained the long-term clinical outcomes. But the clinical data is very limited. But the Ocean 2 trial, they enrolled the younger population, less than 75 years old. They enrolled 370 patients, 1/3 of those population bicuspid aortic valve. So overall findings, there is no difference. A patient underwent TAVR or SAVR, but bicuspid cohort, TAVR associated with numerically higher instance of death and stroke. So it raised the concern about the bicuspid TAVR recently. So we summarized all data, meta-analysis we are doing. So there are lots of sizing, many sizing algorithms. We are, for SAPIEN-3, the Asan Center's algorithm is depending on the calcification volume, and other circle method, wedge method, Casper, the LINA method. So they consider the complexity of aortic valve disease calcification and calcification in the latte. So according to such kind of anatomy, they suggested the optimal sizing algorithm. In addition, associated aortopathy is also important. Personally, I believe that if ascending aorta size is less than 5 centimeters TAVR, we can do TAVR. But the 5.5, between the 5 to 5.5, we can do TAVR. But the more larger than 5.5, surgically indicated, we can do the SAVR plus ascending aorta replacement. But the patient have a high surgical risk, I think we can do TAVR. So what about the meta-analysis result in bicuspid aortic valve disease? I summarized the 28,000 patients from 76 studies. So mean age was 74, male is 56, STS score is 6.7. Interestingly, Pauline spindle valve was done in 42, therapeutic expandable valve was done in 47. PVL, significant PVL is 5%, PPM rate is 12.3, alternating route injury is 0.8, 30-day mortality 2.1, strong rate is 2.3. So when you compare the bicuspid aortic valve TAVR with the tricuspid AS TAVR, the large registry data show that no difference regarding mortality and stroke. SAPIEN-3 registry or EVEROD-R registry, but including the 13,000 bicuspid aortic valve disease and 195,000 tricuspid aortic valve TAVR from the 35 studies, we found that significant PVL increased in the TAVR, PPM rate, no difference. Aortic root injury increased in the TAVR population, major bicuspid TAVR population, major bleeding, no difference. So clinically, bicuspid TAVR is associated with a higher risk of PVL and aortic root injury. In addition, compared with the tricuspid aortic valve disease, bicuspid aortic valve disease associated with significantly associated with higher mortality and stroke. Then, when we compare the TAVR versus SAVR for our bicuspid aortic valve disease, there are just small studies, US study and Finland study show that there is no difference regarding hospital mortality between TAVR and SAVR for bicuspid aortic valve disease. But the Notion 2 trial, I also mentioned before, the bicuspid cohort increased the risk of, numerically, not statistically significant, numerically increased the risk of death and stroke. But our meta-analysis showed that mortality and stroke, the numerically increased, but so far there is no statistical difference between the surgical AVR and TAVR for bicuspid aortic valve disease regarding mortality and stroke. But the complication characteristic is different. High PVL in TAVR population, high bleeding risk in the SAVR population. So this is my summary. Available data suggested that carefully selected patient with the bicuspid aortic valve can do TAVR with the current generation device. Our meta-analysis found increased procedural complication and the risk of mortality and stroke in bicuspid population compared with the tricuspid population underwent TAVR, emphasizing the need for meticulous patient selection, pre-procedural planning, and post-procedural optimization to ensure favorable outcomes and mitigate risks. Given the younger age of many patients with bicuspid aortic valve, reducing the rate of PPM risk through improved device and implantation technique should be prioritized. I think it is important to recognize that not all cases of bicuspid aortic valve are suitable for TAVR, like echo score used for rheumatic MS, a scoring system, or some kind of system specific to bicuspid aortic valve should be developed to guide the decision between the TAVR or SAVR. Thank you for your attention.
Thank you very much, Dr. Ahn. So we have a few minutes for discussion on this. Are there questions from the panel or from the audience?
Dr. Hayashida, so in terms of symmetric expansion of TAV, it looks like the balloon expandable valve is better than self-expandable valve. So is there any your personal guideline when you select the valve type in bicuspid aortic stenosis?
Thank you so much. So actually, I would like to try to minimize the PV as much as possible. That's the reason why I always prioritize SAPIEN over Evolut for the case with bicuspid valve. And if the case has the aortic calcification, I would choose Evolut to avoid annulus rupture. And in terms of asymmetrical expansion, of course, this happens better than Evolut. However, the leaflet of Evolut is a little bit higher than the level of aortic annulus. So anyway, the Evolut leaflet works well, even with the patient with bicuspid valve. But my point is how much we can decrease the PVL, how much we can achieve the better results as good as that of the surgical AVR.
I have one more question to Dr. Kentaro. So I saw your case, so I know that it's very difficult to get the perfect circularity, especially in the bicuspid aortic valve patient. But I wonder in which situation do you use the post-balloon after TAVR in the bicuspid patient?
Yeah, thank you very much. So my initial target is to decrease the pressure gradient and the PVL. And I don't try to reach to the symmetrical expansion because we cannot see that on the fluoroscopy. We can only see that on CT scan. And the next topic will be the potential risk of the subclinical leaflet thrombosis, but we still don't know that if the subclinical leaflet thrombosis is good or bad. So we don't know that much. And the long-term durability is also a big topic, and we're always concerned about the long-term durability. However, there is no evidence that the bicuspid is associated with the worse long-term durability, so we need to see. So I think that the maximize the result of the initial index procedure is quite important by decrease the mean pressure gradient as well as decrease the PBL.
So Ken, you don't routinely do a second inflation for all your Edwards valves? Because you know the data shows that you still expand. Even with the same volume, you get a better expansion. So you don't do a routine second inflation?
If we perform post-dilatation with the same volume, usually it's safe, but sometimes it might cause some risk of aortic rupture because it expands much more. So if there is a need for the post-dilatation, I would proceed to post-dilatation. For example, there is some unacceptable PBL or maybe residual pressure gradient. So I don't do the routine post-dilatation with same volume.
I think we are right at the end of the hour and a half. So this has been a wonderful session, some great cases and some really nice lectures reinforcing a number of the messages. I think the message here is we still are learning a lot about bicuspid disease. We don't know if it's as good as surgery. We don't know exactly the right way to do it. We have a lot of different approaches, but I think we need, just like we've advanced so much for tricuspid TAVR, we need to add that same level of rigor and science to our tricuspid valve. So I hope that Kentaro and Jung-Min and all their teams will continue to educate us on this. Thank you so much.